Hello, everyone. My name is Bianca Gerendas from the Medical University of Vienna. And I am very happy that you're participating today in the EURETINA online webinar about imaging of retinal diseases. We will focus today on looking at different imaging modalities in retinal diseases. We will focus on managing complicated as well as very easy cases. And of course, this is also a very good focus on preparing for the FIBO retina exam that you can take in September of this year. So with me are today 4 great speakers, and I would like to introduce everyone. It's Aude Ambresin, Marko Lukić, András Seres, and Simona Degli Esposti. So I would ask you to maybe introduce yourself very shortly in the beginning, and then I'm happy to start with the first presentation today. So Aude, could you say a few words?
Yeah, thank you so much for having me tonight. Thanks to you, Retina, and you, Dr. Gerendas, for inviting me. So I'm Dr. Aude Ambresin. I'm a retina specialist focused on imaging, and I did my fellowship in Moorfield, and I'm now a consultant in retina in Lausanne in Switzerland.
Marko, what about you?
Hello, first of all, it's a really great honor to be here with you this evening and to give you this talk. So I'm a consultant ophthalmologist, originally from Croatia, not from Italy, but near to Italy. So I'm affiliated with Moorfield Eye Hospital and collaborating with the Institute of Eye Surgery in the Republic of Ireland, and also lecturing ophthalmology at the Medical School of University of Zagreb and at the UCL in London.
Thank you. András. I think you have to turn on your microphone.
Sorry for that.
Thank
I think it's further now. Okay, so I'm András Seres from Hungary. I'm a retina specialist. Nowadays, mostly I'm in a private practice, but I also do surgery for the Medical University in Budapest. And I was trained here in the Budapest University, and I had a very important fellowship in CROATIA, Paris, with Professor Koskas and Professor Giselle Subran.
Thank you very much. And last but not least, Simona, can you say a few words about yourself?
So, good evening, everybody, and thank you, Bianca, for organizing this, and thank you, EURETINA, to organize all these nice webinars to prepare everybody for the exams and for everybody else to get up to speed with everything related to retina. My name is Simona Degli Esposti. I'm one of the consultant ophthalmology at Moorfields. I work in medical retina and research there. So welcome.
Yeah, thank you very much. We're now live with 150 people online, so we're looking forward to some more people to join. But just in case you have to drop out at any time of the webinar, just that you know it will be online afterwards as well. So Marko, can I ask you to give us the first presentation, which will focus on CNV?
Sure. So it's really great pleasure to show you a series of cases which represents with the CNV. So this is my financial disclosure statement, which is basically none. And when we talk about the CNV, it's important to understand that the CNV, or choroidal vascular membrane, is a biological response in different chorioretinal conditions. And probably the AMD is the best one to learn about it. Why? Because we have 3 types of the CNV, and the AMD may represent with each one of them. And when we talk about the CNV, as I said, we have different types. There are 3 types of them. And the main difference how to differentiate them is basically according to their location or to the anatomy. So the very first case is about AMD case, about a 71-year-old lady who attended the MR service with complaints on blurry vision in the right eye. As you can see, the vision was 615, the pressures were fine. The previous ocular history was unremarkable, and the patient was just taking tablets for the regular heartbeat. When we see the color from this photo of that very patient, so which represented with the type 1 CNV, honestly, we can't see too much on this image here. However, just to let you know that the type 1 CNV can also represent with the bleeding, and that bleeding is basically darker in color as compared to the type 1 CNV, which I show you a little bit later. In my view, I think nowadays when we have the OCT scans, the OCT probably is the best imaging tool to see the activity and to recognize the type 1 CNV, which basically, as I said, the types are differentiated according to the location. Type 1 CNV is located in between the Bruce membrane and the RPE, and it represents as something which we call fibrovascular PD or irregular fibrovascular PD, which a presence of fluid which is just above the retinal pigment epithelium, and it represents as a subretinal fluid. On the next image here, we can see the FFA images. So probably FFA nowadays, when you have OCT and geography, are not maybe used so often. However, I would like to show you the images and how to recognize the different types of the CNV using the FFA for a few reasons. Because a lot of literature still explaining the CNV using the FFA, and also some units may not have OCT scans. I think it's important. Also, if we talk about the preparing the exam, it's important to be familiar with the features of the FFA when you talk about the CNV and how to describe those imaging. So you see here that along with the type 1 CNV, I use occult. So occult is an expression which is used when you describe the FFA of the type 1 CNV, where in early stage, which is the left-hand side image, basically you have non-well-defined lesion with some kind of stippled appearance, where that leakage on the FFA, which is on the right-hand side image, is basically increased in the later phase. Later on, I'll show you what is the type 2, and then you will see how easy to differentiate those two types. Of course, nowadays we do have OCT angiograms, okay, which are non-invasive imaging tools. I personally prefer using OCTAs when we talk about the CNV, especially in AMD patients. Why? Because the early patients, the imaging is quick, the imaging is non-invasive. So therefore, I think it's quite convenient to use that. However, the OCT can be tricky if you're not careful. So it's very important to be aware of something which you call demarcation lines and to put the demarcation lines on the right spot. So on the right-hand side, you do have basically the type 1 CNV, which you see that there is those yellow areas is areas of increased flow, which is increased flow within the PED. And you see on the right top image, a nice presentation of the choriointervascular complex. On the left-hand side image is just basically a learning point. When you put the demarcation lines in the wrong space, if you're not careful, if you're in a rush, then you can easily miss the membrane. So that's just one of the take-home messages that I want to take from this lecture. The type 2 CNV is presented in the case 2. Again, it's a type, it's a AMD patient who presented with a sudden distortion, again in the right eye vision, and the presenting vision was 6/12. The patient had a cataract surgery on the fellow eye. As compared to the previous color from this photo here, where the type 2 CNV is above the RP, so we said that type 1 is below, the type 2 is above the RP, is within the subretinal space. Basically, you can see a lesion which sometimes is in grayish greenish appearance, and also you have presence of bleeding. That bleeding is more reddish. Why? Because it's subretinal, as compared to the type 1 CNV, which is more darker. Why? Because it is below the RP. And very often you will see the retinal vessels which go across the bleeding, and that is one of the clinical signs when you look at the patient on the slit lamp, how to recognize the subretinal bleeding itself. Again, we do have OCT scans. So the OCT scans are quite important nowadays, and you can easily diagnose the type 2 CNV using the OCT scans. But you do have, again, as I said, above the RP, something that we call subretinal hyperreflective material, okay? So this is, it represents the membrane, it represents the CNV complex. However, it may also represent hemorrhage, it may represent sometimes a scarring tissue. And therefore, I want that you always try to look all imaging modalities you have on your disposal just to make a proper diagnosis. Likewise, in previous case, the type 2 CNV manifests, the active disease manifests with the fluid, with the subretinal fluid, and also it can be presence of the intraretinal fluid. When we talk about the FFA images, so previously I used expression occult for the type 1 CNV. Now for the type 2 CNV, we use expression classic. Why? Because it has classic features, how we describe the type 2 CNV on the FFA. So firstly, we said that the type 1 CNV is not well marketed on the FFA, whilst the type 2 is well marketed. So you see the lesion in the early phase of the angiogram, and later on, you do have increase in the lesion size and also increase in the leakage. So those are the classical features of the FFAs in the type 2 CNV. Then again, you have OCT angiogram, which when you put the demarcation lines in the right spot, you get a very nice tree of the chorioneovascular complex. There's something that I like to call CNV mimickers. Why? Because they can have features on, especially on the OCT, which may resemble the CNV, but they are not. And one of them is adult vitreform lesion. So clinically, it's very well recognized as a yellowish egg yolk type of lesion. On OCT, it can have that hyperreflective material, but doesn't have fluid. Also, if you do fundus autofluorescence of that lesion, it's hyperautofluorescent as compared to the CNV, which is not. Then the third case is again the type 2 CNV, but it is a myopic patient, 41-year-old female, which represented with sudden distorted vision in the right eye, who had LASIK surgery, but the general health was unremarkable. Where you can see again what I called earlier subretinal hyperreflective material, that fluffy kind of material. In myopic CNVs, you rarely see fluid. So it's important to be familiar what is the active CNV in myopic patients and what is inactive, and I'll show you that soon. I personally like to use OCT angiograms in myopic patients. You should be aware of potential projectile artifacts in OCTAs in myopic patients, but here you can see nicely the membrane. And even better, when you look into the flow, you see that there is increased flow. So those green color is choroidal flow, the red color is retinal flow. So you see that within that lesion here, you have increased flow, which proves the presence of the CNV. As I said, there is no fluid, or very rarely you can see fluid in myopic CNV. When you treat the patient with just a few injections only, you get that nice hyperreflective band above the CNV lesion, and that's OCT sign of an inactive lesion. Then again, in myopic patients, we have another mimicker. So this may look kind of dramatic. So it is a myopic patient with presence of subretinal fluid. However, this is a patient with dome shade maculopathy, which again is not CNV. So as I said earlier, there's no fluid in myopic patients. And again, it's important to be familiar with those cases that may resemble CNV, but which are not. For example, if you treat that patient with anti-VEGF, you will not get too much of the success. Then the fourth case is about a 58-year-old female. It's a MACTEL patient who complained, so was monitored for the MACTEL, but suddenly complained of the sudden distorted vision in the left eye. And here you have image of the same eye 1 year apart. So on the left-hand side image, you have MACTEL patient with a grayish appearance in the macula, with angulation of the vessels and maybe some of the pigment. However, 1 year later, you have development of the CNV, which again, you can see as a presence of subretinal hemorrhage here. And those are the OCT images of the same patient from 1 year apart. So on the top, you have MACTEL case, which you have those intraretinal cavitations, which again, someone who is maybe inexperienced may say it's a fluid or it's a CNV, and that should treat it with the anti-VEGF, which is basically wrong. However, that condition, which I call it a mimicker, may overcomplicate with the CNV, which you can see at the bottom image, and in that case, you should treat that patient with the anti-VEGF. The last case is about the RAP lesion. So this is a type 3 CNV. So it is a patient who is a diabetic, okay, but it is in their 70s, and it has drusen, and it also has intraretinal hemorrhage, okay? So why I mentioned the diabetes? Because those patients with the RAP lesion manifest with the intraretinal hemorrhage. Why? Because the RAP lesion originates in the retina and grows downwards to the chorea capillaries, whilst type 1 and type 2 CNV originates from the chorea capillaries and grows upwards. So that's the difference, again, in terms of the anatomy when we talk about the RAP lesion itself. This is a probably very dramatic case, I would say, or advanced case, where you have presence of intraretinal fluid in the RAP lesion, a PD, a drusen, and on the OCT angiogram, you see a nice increase to the flow in the deep capillary plexus, which grows into the chorea capillaries. If you have diabetic patients who are elderly patients with drusen and have intraretinal hemorrhage, always consider RAP lesion as a potential differential diagnosis. And as a take-home message, I would like to repeat again that the CNV is a complication of various choreal conditions, that crucial event is to break of the Bruch's membrane to develop the CNV and becomes clinically relevant. There are different types of CNV based on the anatomy, that in myopic CNV, the fluid is rarely present. There are conditions which may mimic CNV, but they are not, but they may be overcomplicated with the CNV. So if you have any questions, I will be more than happy to give you an answer on that. And thank you for your attention.
Thank you very much, Marko, for this great presentation and for especially giving us many great images to look at and to show us so many cases with different OCTA images, for example, because I think that's one of the most important modalities we have in CNV. Staying with this question, can you explain actually what a fibrovascular PED is? And do you consider a fibrovascular PED as an active disease? And do you treat it with intravitreal injections, or don't you treat it? Or how do you deal with the fibrovascular PED problem?
Sure. So PED is basically pigment epithelial detachment, and you know that it may be serous or fibrovascular. So fibrovascular, the term is says by itself that it is filled with the fibrotic and vascular tissue. So in most of the cases, if you do the OCTA or the fibrovascular PED, you may find a presence of the CNV membrane. But if there is no fluid there, then I personally don't treat that, just monitor that. So I would say that the patients who have fibrovascular PEDs should be closely monitored because they are under risk to develop the active disease itself. And in case of that, when we define active disease as a presence of fluid, in that case, I start treatment.
Thank you. Simona, would you have a different view or would you agree with Marko?
Here we go. I'm muted. No, I actually work similarly as Marko. I think we are all a bit cautious when we go with fibrovascular PEDs because we don't 100% sure if we want to leave them there or not treat or keep them monitored. But if there is no exudation, no subretinal fluid, or no clear hemorrhage or intraretinal fluid, I usually watch very closely and obviously counsel my patient that any change they need to come in case there is a more activity that can be appreciated over the imaging, really.
Yeah, thank you. I agree as well. And I think probably all of us would treat patients with fluid only. If there's a different opinion, you can say now, but I think we have all probably the same opinion here. So I would like to remind...
Sorry, Bianca, I think that is also a matter of how extensive is this PED, because we know that if they are very, very high PED, there can be also risks with that. So we don't treat if there is no fluid, and we're also quite reluctant in case, obviously, we cause more trouble than benefit, I would say.
Exactly.
But I'm not sure if everybody else agrees, really.
So at this point, I would like to remind our audience that there is a Q&A possibility for you. So if anyone in the audience has a question for any of the speakers, please just write down your question. We will try to focus on the questions during our discussion as well. But now I would like to give you one more question because Marko, you presented us many, many images of OCTA, and I said already it's one of the most important modalities. But which role actually does fluorescein angiography play with CNV lesions? who of you would use FA as a first imaging modality in these patients, or when would you use it? Maybe Aude, could you comment on that? When do you use fluorescein angiography, and how is your approach to that imaging type?
Yeah, I mean, thank you. I think it was really convincing to see in many cases that OCT angiography can actually very well show the MND complex and the flow. And I think if that is very clear to the investigator, I would really agree with what Marko said, that you don't need to actually inject a dye. But I think there is a but in that. OCT angiography is not always so easy to interpret, as you said. I mean, the segmentation is very important to be sure that you are in the right level. And I think that is especially true for PD. I mean, we go back to PD. We know that with PD, it's actually really hard to be on the right level. And sometimes you could think there is no vascularization whatsoever under the PD, but it's there. So I would really recommend, in terms of high PD, to go for dye angiography. But that is, I mean, in certain cases, not for all patients with wet AMD, I would say.
Yeah, András, do you have a different opinion here?
You know, I myself have a very limited experience with OCT angiography, but the opinion what I have about the fluorescein, that might be strange, but I would like to share it with you. Many years ago, I was asked to participate in a course for pediatric ophthalmology, and the title was The Indication of Fluorescent Angiography in Children. And I refused, because my answer was that why shall we do fluorescent angiography in children? And the answer was that when we don't know the diagnosis. And my answer was for that when you don't know the diagnosis, please ask somebody who knows it without fluorescent angiography. And with the OCT technology, what we have now, I have to say I have something similar in opinion, because in most of the cases can be diagnosed without fluorescent angiography. Although I was a big fluorescent angiography guy, I had a lot of courses on that, but nowadays I rarely perform it. And when my colleagues ask me for that, usually I ask them to show me the OCT or maybe the fundus autofluorescence. So that might be strange. I would like to know your opinion about that.
Yeah, so I also have to say that I do like to use OCTA, but with caution. So there's many cases where we have segmentation difficulties, as Aude said, and where we really cannot really convincingly say there is a CNV or this maybe a projection artifact or whatever it could be. So I personally think that there's many cases where fluorescein angiography also can make sense if the diagnosis is not clear, especially in cases where we have myopic CNV lesion thoughts or maybe CSR. There, I think this is also always a valid approach. But unfortunately, even though I think just with this topic, we could probably fill the entire hour, we have to go to the next topic because we want to see some more imaging cases. And therefore, András, I would ask you to talk a bit about diabetic retinopathy and edema.
Okay, thank you very much. First of all, I would like to thank you and the organizers for inviting me. When I first received the topic, what I have to talk about, I thought that's impossible in 10 or 15 minutes. So that's a mission impossible. So I would think that I might talk about artificial intelligence and how artificial intelligence can help us in differentiating different levels of fluid in diabetic cases. But then I decided that I might try to show how the natural intelligence with the OCT images can help us in differential diagnosis. I will show you 4 cases and I will ask questions, but at the meantime, at the same time, I will also give the answers because it is not a good forum for waiting for the answers. So I will have 4 cases. The first case is like that. That's a lady of 41 years. The other eye is already blind for the complications of proliferative diabetic retinopathy. This eye, as you can see on the upper part of the image, that had a very severe tractional detachment at the macular area. And what we did was a bevacizumab injection, and a week later, a pararetinal photocoagulation, the bevacizumab injection, and then pars-plana vitrectomy with silicone oil, because we needed the silicone oil not because of a complication, but because we simply wanted the patient to see soon after the surgery. So 1 month after surgery, the visual acuity was 0.5. And you can see the image here with some subretinal fluid. So I have some questions, and these are practical questions which I might ask my colleagues or my young colleagues, my residents around me. So if we have a look, we have some tiny dots above the retina indicated with the blue arrows. My question is what these dots can be. And the good answer is that these are small droplets of silicone oil in between the retina and the silicone, the back surface of the silicone oil. So not inflammatory cells or something like that. I always ask the colleagues, I think the retinal specialist should know the exact layers on the OCT image. So my second question would be, in which layer the cystoid spaces are located in? And in this particular case, these cystoid spaces are located in the inner nuclear layer. So the red arrow indicates something strange above the subretinal fluid. It seems that something is missing there. I call it gap. And my question is, what is the gap, and is it a good sign or a bad sign? Long term, the subretinal fluid will probably go. And the answer is that the gap is caused by some missing inner and outer segments of the photoreceptors in that small area. Although on the left, from the green line of the OCT, we still have these so-called shaggy photoreceptor segments, which is also seen in cases like central serous chorioretinopathy. If it is a good or a bad sign, I don't think it's a bad sign, because in my view, if the patient has an intact external limiting membrane, that means that the centers of the photoreceptors are intact, and after retouching the retina to the pigment epithelium, the photoreceptor cells will regain the outer segments and the inner segments. Another interesting thing that we can see some kind of fog underneath this gap. It is indicated with this yellow or amber arrow. I don't know whether it is well visible here. And I think we might have the same particles everywhere underneath in the subretinal fluid space. But we can see these particles here. Maybe that's noise, only because we have a transmission effect, because a very high barrier of the transmission of the rays is the outer segments of the photoreceptors. People think that the transmission blockage comes only from the pigment epithelium, but that's not true. We still have a transmission effect when the photoreceptor outer segments are missing. So these small dots here might be only noise, but these are more visible here only because of this gap. So there are some things that I might ask my residents if you see an image like that. So I would like to show a second case. That's a 31 years of female with type 1 diabetes mellitus for 20 years. The visual acuity is quite good. No real complaints with the vision. And I have to note that that's a horizontal scan. And the first question I ask, is it the right eye or the left eye? Some colleagues might have different difficulties with that, but if we consider the left hand side of the image here, we can see the nerve fiber layer with no nerve fiber layer on the other side. So that means that that's a left eye. That's a crazy question, but I think we should teach the young colleagues to think like that. The second question is, where is the fovea of the patient? Is it the red arrow or the blue arrow? Probably the patient does not have two areas of fovea. And do we have any thoughts on the retinal circulation according to this image? We don't have OCT and geographic. I think I answered the last question first. If we consider the inner nuclear layer here, it has irregularities, very, very pronounced irregularities, and that is a sign of very, very disturbed retinal circulation. And actually, these two areas are not the fovea, neither of them. And that's because these thinning of the retina in both places are because of the bad circulation of that particular area. I show you now the real fovea of the patient here. The image before was somewhere here, a little bit upper. And if you have a look, we have some irregularities of the surface of the retina because of the bad circulation of the middle layers. And I have a question. This is the color photo of this eye, and why we have no microaneurysm visible here, neither on the color photography or on the OCT infrared image. And that is simply because of the disturbed circulation of the eye. One last question about this image. Probably most of you know that, but I have to ask it because I have seen patients who were treated because of this small hump here that was called pigment epithelial detachment or subretinal fluid or central serous retinopathy. And actually that is simply the so-called clavus inversus, and that is a normal phenomenon. So please do not treat anybody because of this hump here. And the last question is, if the patient needs any treatment, the visual acuity is 20/20. And the answer can be seen here, or at least partly seen here on the optic nerve head, because this patient has neovascularization on the disc. And if a neovascularization on the disc comes with some vitreous hemorrhage, that is an indication for pararetinal laser treatment. And I show you these 4 images because the visibility of this small area of neovascularization is different on the 4 images. First of all, it is not visible at all on the infrared reflectance image of the spectralis OCT, although here, near the optic nerve head, we can see some kind of neovascularization as well. And if we consider these 2 photographs in black and white, both are red-free photographs, it only shows that when we make the exposition correct on the retina, the optic nerve head might be too white, and the vessels are not visible here. So in order to see such details, one might make some adjustment on the exposition of the camera. So this was my second case. This patient received pararetinal photocoagulation. That was a difficult case, but there are some signs of images what I would like to show you and show to the audience. First of all, I have to emphasize that I consider the red-free photographs much more important than the color ones, because you will never see the vessels so nicely on the color photographs. The colors are very beautiful for the textbooks and for teaching and maybe for the congresses, but for the everyday work, I believe that the good red-free photographs has their value. So that's a relatively bad case. The guy is quite young. The visual acuity is very bad, and he has a strange tractional detachment of the whole macular area. The other eye is already blind. So the only thing what we might try, it's risky, to perform vitrectomy for this case. And that is an image 1 month after surgery. My question to my residents would be, what is our visual acuity estimates? What can we hope from this case? And we already have the fovea here, good news. But if you try to follow the layers, you can follow the plexiform layer to this point, maybe see some external limital membrane or some ellipsoid, but nothing exactly at the center. So this patient will probably can have only some kind of extrafoveal fixation, and the visual acuity might be limited to 0.2, 0.3, or something like that. So the second question, that we can see some extra signal transmission here. And in my view, the answer for the cause of that, you can see that the pigment epithelium looks quite healthy here. Still, so I think the answer for the hypertransmission is going the missing outer segments of the retinal photoreceptors. And we can again see some small particles here. These are small droplets of the silicone oil. Even 1 month after the vitrectomy, it is visible between the retina and the silicone oil surface. So this image is the same patient 4 years after the removal of the silicone oil and the cataract surgery. And please have a guess what the visual acuity can be. I give the answer that is about 0.3, or the patient has difficulties with finding the door. The other eye is completely blind. So on the chart, he can read quite well. 0.3, I think in the situation is a good result, but the visual field is terrible, probably because of the circulation of other parts of the retina. And the situation here on the OCT, one might say that that's a lamellar hole, but that's very strange to have a lamellar hole in this situation. And I think that the cause of this lamellar hole, actually, that is a plica of the retina caused by this area of epiretinal membrane. And the question was what to do in this situation 4 years after surgery. Shall we do a second vitrectomy for removal of this epiretinal membrane? Actually, that's the third vitrectomy. And my answer was no, because that was not causing the bad vision of the patient. That was because of the atrophy of the outer retina at the foveal region. So I try to share with you a fourth case. That's a female of 46 years. The right eye, not shown here, is on anti-VEGF for injections for diabetic macular edema for a long time. And we have questions now for the left eye. As I already mentioned, the red-free photograph shows us much more information than the color. That's a thing that I would like to emphasize. And the first question is, according to what we see here, do we have a macular edema requiring treatment? We should go back for the definitions of the clinical significant macular edema from the anti-DRS trial. And yes, we can see some areas of exudates very close to the fovea. I show you the OCT image and the fluorescent angiography. On the OCT image, okay, there are some cystoid spaces here, but I don't think that at the time of the anti-DRS, without OCT, anybody would consider that as a thickening of the retina. We do have thickening of the retina on the left side of the image, but that is not due to real edema, that is due to a tractional component from the neovascularization of the optic nerve head. So what treatment shall we do? So our idea was that that's a case of proliferative diabetic retinopathy with high-risk proliferation, so pararetinal laser treatment should be done. So that was performed. After the first two sessions, that was okay. But after the third laser sessions, the patient came back with an image like that, and the visual acuity went down to 0.3. So the question is, what can we do now? One possibility might be inject anti-VEGFs here, but we decided that we might make the tractions worse. So we decided to perform vitrectomy for this case. That is 7 months after the pars plana vitrectomy. And in this 7 months, the patient also received 6 injections of aflibercept. Visual acuity is still not improving. The edema is better than it was soon after the vitrectomy, but it is far from being perfect. So what shall we say about the theoretical prognosis of this eye if we can get rid of the edema? In my view, we can see quite normal outer retinal layers here. So in case we can get rid of the edema, the visual acuity might be quite good. So what kind of further therapy needed? The patient had 6 aflibercept injections in the last half a year. So at least it means monthly. So shall we switch to another anti-VEGF or to steroid implants? Or shall we do a second vitrectomy with the membrane paling? That was my question. And my decision was to make a second vitrectomy for removing these epiretinal membranes here. And that is more than 2 years after the second partial vitrectomy. With bevacizumab every 10 weeks now, the patient is really asking to have the injection. She's afraid of losing the vision, which is perfect now. That is 86 letters on the LTDRS. That is 20/20. So I think, as I showed you, the outer layers of the retina, when they are so intact as I showed you in the last images, can be very predictive to what we can expect from the patient. And I think that is my last slide. Thank you very much. And if you have any questions, I will try to answer.
Thank you very much. I'm very sorry, due to the timing, we will not be able to discuss anything about diabetic retinopathy, but thank you for the interesting cases. And we will move right on to Aude and the topic of geographic atrophy.
Yeah, thank you so much for giving me this opportunity to EURETINA and to Dr. Gerendas for inviting me as a speaker. And my topic is how to monitor geographic atrophy. So I think we've all seen that multimodal imaging is so important in retinal diseases, but I think that is even more true in geographic atrophy because there is an interpatient variability that is really important in GA, in dry AMD, and also, as you're aware, we are entering a new era where treatment might be available. So basically, we have many imaging modalities, but due to time constraints, I will focus on optical coherence tomography, fundus autofluorescence, and infrared reflectance imaging. So we will start with the OCT. And I think when referring to OCT in geographic atrophy, we refer to the classification of atrophy meeting as known as the CAM consensus. First of all, you have to be aware that geographic atrophy is a specific terms to describe macular atrophy in setting of dry AMD, because macular atrophy you will find in other conditions. And this CAM consensus really provides a more detailed definition of atrophy based on OCT. And these are criteria that we as clinicians can use, and they're valuable to understand the stage of the disease. And as I said before, in terms of treatment, maybe it will be also very helpful. So let's start with this first imaging modality of OCT and GA. The first thing that you should know about, and that will probably come as a in the exam of the FIBO, is this definition of I aura and C aura. So what is that? So the I aura is the incomplete outer retinal atrophy. And here you have like the arrows showing you the different imaging that, signs that you should look at. So I aura is a continuous external limiting membrane, intermittent ellipsoid zone, and a non-visible IZ. You can see that there is a thinning of the outer retina, but there is an absent choroidal hypertransmission. When it comes to complete outer retinal atrophy, you will have a continuous non-visibility of these three ELM, EZ, and IZ, but a very severe thinning of the outer retina. And now you do have, as we call, a hyper signal of hypertransmission in the choroid. The second sign that you should look at on OCT when looking at GA is I-RORA and C-RORA. What is different here is you have this R, which comes from RPE, and incomplete RPE and outer retinal atrophy, or complete RPE and outer retinal atrophy. So basically, maybe one thing that is very practical that we can use in clinic is that this I-RORA is also called nascent GA. So here you have an interruption of the outer retinal layers, RPE interruption, and inhomogeneous choroidal hypertransmission. So again, you find this hypertransmission. And the end stage of that is the C-RORA, where you have the complete RPE and outer retinal atrophy, which is called complete GA. Loss of outer retinal layers, obviously nothing can be seen there, absence of RPE and photoreceptors, and also this important choroidal hypertransmission, which by definition should be more than 250 micron. So I also think that you should look at this place called termination of RPE, because this on this complete RORA, because this is called the junctional zone, and there are also prognostic factors in this junctional zone. You can have it either smooth, either rough, or also splitting, which means the splitting of the Brooks membrane and the RPE, and a bit of also enlargement of the outer nuclear layer. And the splitting of the junctional zone is also used as a prediction for progression of GA. So basically, remember IORA, IRORA, IRORA, and CRORA, and the junctional zone as important sign that you should look at on OCT. First case here, CRORA or IRORA, as my colleague did. I mean, it's not really done for questions, but this is obviously IRORA because you have an interrupted RPE, interrupted EZ and ELM, but an inhomogeneous hypertransmission, as here, we would all agree that this is a complete absence of RPE and photoreceptor and homogeneous hypertransmission. The second modality I want to talk about is fundus autofluorescence and GA. Of course, that is really important because I'm sure you're all aware that this is the reference, the standard for the regulators in terms of like FDA and EMA to look at treatment efficacy. So we can characterize fundus autofluorescence by size, location, focality, and pattern, and that's what we're looking at together. We're going to speak about blue light autofluorescence because that is the standard for 188 nanometers. First, the size, small or medium, the bigger, the more it will progress. The location, whether that is foveal or extrafoveal. Whether it's extrafoveal, it will also progress quicker. Focality, whether that is unifocal or multifocal, multifocal will progress quicker. And the pattern, whether there is no autofluorescence whatsoever, whether there is a little small point of focal autofluorescence, as you can see here in the middle of the first row, patchy, banded. What means banded? It means that you have this band of hyperfluorescence around the atrophic zone, diffuse, or even more so, diffuse trickling. And that is important because both banded and diffuse trickling are prognoses for progression. So again, case 2 here, what is this AF pattern that you see here? It's obviously banded because there is a bit of hyperfluorescence around the image, or down the diffuse trickling pattern. And again, just as a location, that is multifocal, meaning more progression. And remember that you have these medium-sized, multifocal, extrafoveal, banded or diffuse. That means these are progression prognostic signs on autofluorescence for faster progression. Here you have a case that I want to share with you. This is a patient that was seen like a year, a bit more than a year apart. And you can see that the progression using the region finder on this autofluorescence, blue light autofluorescence on Heidelberg, actually show a 2.2 millimeter square per year of progression, which is as the higher zone of the usual median progression, that is 1.78 millimeters square for the like, median progression for GA in a general cohort, as it was demonstrated in studies. So this is a fast progression because it is extrafoveal, and you can see that it's quite diffused, that you have this diffuse trickling pattern. So that is the second modality. And for the last one, which is the quicker one, but I still want to share something on this important modality, which is the infrared reflectance. Why is that? Because infrared reflectance actually allows a detailed evaluation of the RPE choroid another deeper layer, but RP is very important. It is also more comfortable for patients to comparing to blue light. You know, it's very bright, the light for blue light autofluorescence. And actually the central macular luteal pigment absorb the blue light, rendering sometimes blue light autofluorescence not so optimal for the evaluation of foveal involvement. And that is important when you consider patient for evaluation for progression, but also maybe later on monitoring treatment effect. So let's confirm something. Here you have a blue light autofluorescence. It seems that the atrophy is actually involving the fovea. But when you look at this infrared, you can see that there is a foveal sparing. So I think it should be in the armamentarium of multimodal imaging in GA to please remember the importance of infrared reflectance imaging. And with that, I'm going to conclude my talk with this fourth case showing the three important imaging modalities. So fundus autofluorescence using blue light autofluorescence. As you know, the lipofuxin, the fluorophore of the blue light autofluorescence, does show a bit of hyperfluorescent perifoveal ring here, but not so obvious. But now when you look at the same patient and you look on OCT, there is actually very much an eye aura. You can see that pigment epithelium is still there, but outer retinal is completely disrupted. And adding infrared reflectance, you will now see other signs showing that this pigment epithelium is really there, but has changes. So basically, remember that there are different multimodal. Multimodal is very important in GA, but I think these blue light autofluorescence, infrared, and OCT are crucial for GA detection and monitoring probably in the future progression. And with that, I thank you for your attention.
Thank you very much for this very comprehensive talk. And I think after this, no one will ever ask again, what's the difference between iRORA and CRORA, and iRORA and CRORA. So I think as we are short in time, the faculty has already started to answer the Q&A questions in writing, so everyone can read them if you're interested. And we will continue to do so if you ask more questions. But nevertheless, I would ask Simona now to give us the last presentation about retinal imaging in inherited retinal diseases.
Thank you, Bianca. So thank you for all my co-speakers, and they already pointed out quite a lot of important information about all the imaging modalities. So when I speaking to Bianca and obviously setting up this webinar, I've also been given a very difficult task about talking about retinal imaging on IRDs. It's a very, very broad topic, but to my help came a webinar from Omar Marou and Maximilian Plau that was done in May, where they all already spoke about inherited retinal diseases in quite a broad point of views. And therefore, I just want to do a small overview of imaging in IRDs, just for food for thought and for help, obviously, for the colleagues who are preparing the exam. So as we said, obviously, IRD has very heterogeneous phenotype, and so they're very difficult to diagnose. They're very difficult diagnostic challenges, because even experienced physician can find it very difficult to understand what is the cause of IRD, which is gene causative. We're looking at fundus of the patients. And obviously, multimodal imaging, like Aude brilliantly said, is actually what comes to our help. And same as Aude has mentioned before, there are different modalities, and we are actually looking here very similar modalities that what Aude has mentioned for geographic atrophy, talking mostly on the remit of OCTs and ultra-wide field and fundus autofluorescence. So I just wanted to show a few cases about more generalized retinal dystrophies and more macular dystrophy, just for our interest and discussion. This is a first case, and this is a quite simple case to diagnose, I say. And I think we all will hope that our diagnosis for the retinitis pigmentosa could be as straightforward as this one. This is a color fundus, and this is autofluorescence. And I think we will agree that this patient looks like he had a quite profound retinitis pigmentosa, quite advanced retinitis pigmentosa. And actually, this patient was a autosomal dominant RP caused by RP9. And in fact, this patient has a very strong history of retinitis pigmentosa and lost most of his vision in his 20s and is now perception of light. But how easy is really to diagnose retinitis pigmentosa as such? Not really, because as you can see here from this nice vignette from Peter Cialbellissa group, quite a few cases of ABCA4 or RP or RP sine pigmento may have a very broad spectrum of appearances. They all classically have this ring on hyperautofluorescence, where there is stress of the photoreceptors, and classically with the retinitis pigmentosa, the ring will narrow down towards the center, which our first patient didn't have as it was so extensive. Oh, sorry. Here we go. A few other cases I would like to point out, again, from this beautiful review from Professor Michelidis' group from Moorfield in my institution. We're seeing here some cases of autofluorescence and OCTs for autosomal dominant RP. As you can see here, the ring that we were mentioning, and obviously correlated to the layers of the OCT, which are going to be missing. Second is X-linked RP, where obviously you can see quite a severe atrophy in the foveal zone, in the macular zone, and other appearance with the sector RP and enhanced cone syndrome. Another case, a different type of condition. This is a patient with having disappearance of fundus autofluorescence and colors. And again, is a very pathognomic type of features of the fundus. I'm going to show you the OCTs as well, because they are very characteristic as well. And I think we will all agree that this patient has choroideremia, and obviously positive for the genetic test. Choroideremia can have, again, a different spectrum of features, and in terms of differential diagnosis, there are different conditions that can mimic that. And here in the vignette, we can see a gyrate atrophy on the third pictures that can obviously need to be not confounded with that. Multimodal imaging again here for the choroideremia, just as a reminder, there is a very diffuse atrophy, and that all quite relative in the RP as well. Choroideremia, as you know, I just wanted to show here what could be a carrier, because when you look at IRDs, obviously you will have to take a family history, like they outlined in the RD seminar. And choroideremia carriers can have a very broad spectrum of features, depending on where obviously the degree of X that is affecting the mom of the patients affected. And in this case, you can see that fundus autofluorescence and color were significantly changed. A quick note on macular dystrophy. Here, a case of macular dystrophy. You can see here a white fundus image where there is not really much to see in the periphery. And actually, when we do autofluorescence, we see that the disease is very localized centrally, where the autofluorescence has a very hyper ring with a very high autofluorescence in the central part. and that reflects very beautifully in the OCT, where you can see there is a significant atrophy of the foveal zone and atrophy of the photoreceptors layers that reflect on the autofluorescence, as we just seen. Again, diagnosis, quite straightforward diagnosis, possibly for people who have been familiar with RD conditions. This patient has Stargardt disease, and specifically type 1, has the periphery is relatively unaffected. And here we have some idea on differential diagnosis with Stargardt disease, and we have Stargardt disease on the left side, but best can have a similar appearance when they go to eruptive phase, while here obviously we still have some deposit underneath the fovea. And here X-linked retinoxysis, as you can see, a very peculiar appearance of the retina with this disruption within the layers. Few other macular conditions that we need to be familiar with: Sorbis fundus dystrophy, which is very, very confined in very patients' populations, more generalized pattern dystrophy, and autosomal drusen on the right-hand side. As we can see, the cone dystrophy and cone rod dystrophy can have very, very different patterns. And it's not easy when you're looking at the pictures just to find yourself what could be the specific causative gene. And for the sake of the colleagues who are doing the exams, I think that what is important from your point of view, obviously getting familiar with the more frequent conditions, and obviously explain and describe what you see on the fundus autofluorescence and colors pictures, and explain where you think that the pathology can be coming from. Fundus autofluorescence in the macular pathology is very helpful, like Aude has again outlined previously. That can be helpful also in the inherited retinal diseases. And here you can see how Giulia Corradetti and the SADA group have measured how the difference in autofluorescence over time in the Stargardt disease can be nicely evaluated with autofluorescence. One last point in terms of blue light autofluorescence and near infrared autofluorescence. I can see Aude nodding and smiling. Obviously, Aude has been talking about blue light autofluorescence, and obviously we need to be aware there is also near infrared autofluorescence, which is here on the right side of these pictures, as opposite of the blue light autofluorescence on the left, because it's quite important also to use this modality if you have it available at yourself. Obviously, near infrared autofluorescence, you lose a different wavelength, a bit of a longer wavelength, and so is less energy that goes into the eye of the patients. And as you know, there has also been thought and clinical statement also from the American Academy in making sure that the patients with the macular pathology can have the least autofluorescence exposure to try to protect the retina as much as possible. And here you can see how the different condition can look like from Peter Charbelli's team group paper. One last word in terms of, okay, we have seen all these imaging modalities for the inherited retinal diseases. Don't forget that OCTA and fundus autofluorescence are very helpful still here, because some of these conditions can develop CNV, like Sorsby or BEST. Obviously, we don't do fundus autofluorescence anymore in cases like Stargardt disease to see the dark choroid like we were seeing back in the days, and possibly only something that we can see down in the books these days. But the OCTA and the fundus autofluorescence was still very, very valuable in case you're worried that there could be some CNVs, especially in Sorsby and BEST, which are a bit difficult to diagnose. I'm citing here the papers and the reviews that I've been presenting in my slides. They are all very helpful, and they're all looking at imaging in IRDs under different aspects. And I would encourage you all to read through them and getting familiar with all these different conditions and features. And I'll hand it there. Thank you.
Very much for this last presentation. Due to the timing, unfortunately, we will not have the possibility for discussions during this webinar, but we try to answer as many questions as possible in writing in the Q&A session. So I would like to thank, first of all the speakers for preparing the very interesting presentations and the cases of major importance to all of us in the clinical practice. I would like to thank EURETINA for organizing this webinar, and I would also like the imaging section members, especially Tunde Peto and Stella Vujosovic, for heading the imaging section of the EURETINA. So last but not least, I of course like to thank all of our webinar attendants for staying here until 5 minutes overtime, and I wish you all a very nice evening and good luck in the exam. Goodbye.
Bye-bye. Thank you.
Bye.
Bye.